My name is Michael Sayers. I'm one of the trustees of Dissupport UK, and on behalf of my fellow trustees and the chair, Barbara Dorry, who unfortunately cannot be among us this morning, I'd like to welcome you all to our Dissupport UK conference, one of two that we have each year. It would be interesting to know, is there anybody, how many of you are here for the first time as a GIST conference? Quite a fair number. Well, I hope you find it as productive and an informative day as those of us who have been coming rather longer have found it. A couple of things that I need to say. I need to say that Dissupport UK is run by volunteers. All the trustees are volunteers. And I've also been asked to say what we can and what we can't do. What we try to do is just provide information based on all the latest information that we get from various sources. What we can't do is give individual medical advice, because we're not doctors, we're not medics or oncologists even. Most of us are either patients or carers. We've recently, just this year, changed our logo slightly to include the word reference to the fact that we are a cancer charity. Oh dear. Oh yes, toilets. Toilets are unfortunately not on the same floor as us. You have to go out to the right and down some stairs. But there is a lift. If you walk far enough, you will eventually find a lift down, but it's probably quicker just to go down the stairs. Right, level C for anyone who didn't hear that. There's going to be a fire alarm test at 1 o'clock. I'm assured that this is just going to be a test and we don't need to do anything. And Judith has got kind of a legal announcement to make.
Couple of other things. We are being filmed, so if you don't want your face on camera, perhaps you could tell our cameraman and he'll avoid you. The other thing is, for legal reasons, I have to say that we have representatives here from Pfizer and Novartis. Where are you? I can't see you. It's Barbara and, they're sitting together over there. Barbara and Debbie, that's right. And Pfizer and Novartis have helped fund this meeting, but their attendance at the meeting is at our invitation. That is a legal statement I have to make. Have I said that right? Okay, thank you. Is there anything else at this stage? No, we're really sorry Barbara's not here, so various of us are sort of playing at being chair. I don't think there's anything else at this stage. No. Sorry? If anybody doesn't want their photo on social media like Facebook, let Debbie know, because I think she's going around with a camera with one of these little phone thingies, taking pictures as well. So if you don't want to be on Facebook as being here, or Twitter, do you put photos on Twitter? Oh, okay. I don't Twitter. I don't think there are any other sort of housekeeping things. And now we ask Ramesh, or is it Ramesh? He's here. Who's going to fill us in about where we are with just now. Ramesh.
Thank you very much indeed for asking me to come to this meeting. I've been coming almost 10 years now? 2005, 2006, London, small meeting, few people. It's been a long journey and mostly fruitful, and looking back, it's been quite scary as well. back in 2002, when we had the first GIST patient in Cambridge, and 2003 we had the first pediatric wild-type GIST patient. We knew not. Actually, I knew nothing. I knew nothing about GIST. Never heard of them. Vaguely knew what they were. As a registrar to Professor K in Glasgow, I was giving chemotherapy with ifosfamide and doxorubicin. That was not too long ago. That was 20 odd years ago. And we had 2 patients in 2003 in Cambridge, 2 GIST patients. That's all we had. And the clinic was, yeah, come in, have a cup of tea, and then, and that's it. Now we have nearly 250 GIST patients. And what we have done in Cambridge, which is kind of unique and possibly a bit mafiosi kind of thing, is that we don't allow anybody else to treat GIST in Cambridge. There's only one team, and that's it. The 42 oncologists in Cambridge, or Cambridge network, there's only one team for GISTs. And you cannot prescribe imatinib or sunitinib or regorafenib outside the team. And that's the kind of thing which I felt was the right thing to do back in 2004 when we formed the GIST study group. We have centralized the surveys, the surgical surveys, to Cambridge. That means nobody else operates outside unless it's a surgical emergency. And the pathology is centralized, and the radiology used to be just Nick Carroll, one person. Now we've got 3. So the radiology is centralized, and we have a GIST specialist MDT in Cambridge. So every patient, new diagnosis, and also patients who had scans while on treatment, their management is reviewed. What I would like to do is just take you through some of the things we've learned in the last 10 years with regards to the diagnosis of GIST, how they present, and also the treatment options, both in the adjuvant and the metastatic setting. And the last 15-20 minutes, I'm going to focus on the wild type, the pediatric wild type, just because that's my obsession at the moment. So let's get this up. Whose laptop is this? Whose laptop is this? My laptop. This is ancient. Not you're not ancient. It's just the laptop is ancient.
It's ancient but refurbished and functioning perfectly in the right house.
Right, where's your play button?
Down.
Where?
We'll get there in a minute. Well, you stand up, I'll do that bit if you like.
Oh, there it's here. Okay.
Yes.
Okay. No, I'll do it. No. So that's my disclosures. So I'm going to go through some of these things. Some of them might be super fast. The problem with me is that I tend to speak very fast anyway, so I apologize. I'm going to touch on the wild type just in a separate presentation, just to look back to where we were. Memories are actually very fond. We actually look back and say when we were kids and we were teenagers and so, but just wasn't a good thing back in the 1980s, 1990s, even early part of the 21st century. So before Gleevec-Sutent era was passed, presently we are in the Gleevec-Sutent era, and the post-Gleevec-Sutent era is regorafenib, which is now present. And the learning curve has been very steep, very rapid, and we actually sometimes look back, you sometimes feel that you're a bit dizzy, because from knowing nothing back in 2002 to 2003, now claiming to be specialists in this field is actually quite scary. So GISTs are rare, and 15 to 20, which fits in with what we have seen in Cambridge over the last 10 years. In Cambridge, what we've done is We have been collecting data on every single GIST patient. Doesn't matter how big the GIST is, how small the GIST is, 0.2 millimeters up to 20 centimeters, 25 centimeters, doesn't matter. Every single GIST patient, every single data has been collected prospectively since 2004. So our incidence is about 15, around 15, 16 per million. And we have patients under the age of 40, but majority of them around 60, 65, 70, that kind of age group. We have not as yet seen familial GIST, confirmed familial GIST in this country. There's one patient family, mother and daughter have GIST. The daughter has moved to Australia, but we don't think it's actually familial. But we have syndromic GIST. I'll come to that in a minute. So, other thing what we're picking up is the asymptomatic GISTs. We are seeing quite a lot of them. Maybe we are looking for them. So patients who are being investigated for something else, or they may have some other cancer, and they have a scan done, or they have endoscopy done, we find a GIST. So GISTs are becoming more common in the asymptomatic phase. And this is the French data, and we now know that GIST is the most common sarcoma. And this reflects not just in France, same thing in Germany. They're going to publish the data very soon, and I suspect the same is in this country as well. Just to recap, they arise from these interstitial cells of Cajal. Cajal, back in 1906, got a Nobel Prize, not for describing his cells, but describing some of the other neuronal networks. He's a Spanish physiologist. And these are the pacemaker cells which propel the food and everything what we eat down the digestive tract. And this may be one of the reasons why the GISTs are more common in the stomach. There's a highest concentration of ICCs in the stomach and the esophagogastric junction. And as you further down you go towards the small bowel into the rectum, the concentration of ICCs tend to get lower. So it may be one of the reasons why we see more GISTs in the stomach area. And then as we go down the digestive tract, we have lower incidence of GISTs. And we do have to remember Seishi Hirota, who had the opportunity to meet him in Helsinki, one of the GIST meetings. And without him, we wouldn't be here. Without he describing the gain of function mutations in the KIT gene back in 1998, and that was the starting point of the journey. And then Dave Tuvison, who was very briefly in Cambridge and he went back to America, he described when he was at Dana-Farber how you can actually block off the activated KIT by using the imatinib in the in vitro cell lines. At the time it was called STI 571. So that was a critical moment in the history. As I said before, the most common site is stomach. CGSG stands for, you can't see it here, but it's a Cambridge GIST study group. We see more of stomach GIST than the published series. Very rare in the esophagus, and if you see anything like GIST in the esophagus, often it's a leiomyoma, as a smooth muscle tumor. Majority of the times, we only had 1 or 2 GISTs in the whole of the population and the esophagus, and they're almost certainly near the junction. And that's what they look like. Sorry for the horrible pictures. When I see we're seeing more GIST, it's partly due to the pathologist who's picking up tiny, weeny microscopic GIST. See that one there on the left top corner? That's a sub-millimeter GIST. And the pathologist is quite obsessive. We're picking up these things, tiny ones. They're not causing any trouble right now, but we're picking them up. And they stain for CD117, DOG1. They do have the primary mutations as well. Metastatic spread. We know that patients with GIST do develop secondaries, often the liver peritoneum, and sometimes local recurrence. We have seen bone and lung lesions as well, and very, very rare to spread to the brain. We only had 1 patient who had a parameningeal mass, but not in the brain. So the most common liver in the peritoneum and very rarely in the bone. And this patient, who's a favorite patient of mine, all of them are favorite, but she's more favorite because She keeps on relapsing just there. Nowhere else does the laparotomy scar, where she had the primary gist removed. 3 operations she had. The surgeon got fed up. I didn't want to operate anymore. It's exactly the same tumor. Comes back, only one location. Never had liver metastasis, never had peritoneal metastasis, nowhere else. Over a 10-year period, she had 3 recurrences just in that area. And it was exon 9, and actually it was in the stomach, very rarely. Stomach, exon 9, very rare, but very unusual presentation. Just want to briefly touch upon the National GIST Registry we have developed about 2.5–3 years ago, which is now been taken over by the NCIN, which is the National Cancer Intelligence Network in England. And this was based on the database we have developed in Cambridge. And we have this is a web-based registry. We get in with the username and password, and you put on the details, including the demographics, and the tumor site, symptomatic or asymptomatic, and how did they present, and tumor histology, and also if there are any metastases, you just tick the boxes. It takes about between 8 and 10 minutes to put in. And you got a report at the end. You get a standard report. You can actually work out how many patients are imatinib, how many patients are sunitinib. And what has happened is that, so the patient actually sign a consent form after having had an information sheet. And this is what we want to collect. The incidence of GIST, the pathways, surgical data, treatment outcomes, rare subtypes, wherever possible, the mutational status data, and clinical trials as well. Since we set up that registry, we had run into problems, partly because of the way we set up the registry. We put it as a clinical trial rather than actually as a database. The problem with that was that we ran into data protection issues and everything. What happens in NHS, you can't talk to Miss A or Mr. B without having gone through that. So what we felt was that we had a big meeting in Birmingham with the cancer registry team, and they were very helpful. And what we felt was that to overcome that kind of this data protection issues, the cancer registry is already collecting this data anyway. So what we felt was the best thing would be to piggy bank the GIST registry onto the National Cancer Registry. And that means the data is collected through the cancer registry. They're mandated by law to collect the data anyway, so we don't have to go through the things we're going through in individual hospitals. So the plan would be to try and get the extra data we are talking about. They're collecting the epidemiological data, the demographic data, tumor site, et cetera, but try and collect the extra data we want to collect, which will be of clinical use, and also for the patients as well. So that's what we are planning to do, and hopefully we should get some data out in 2015. There's something which we have learned in the last 10 years. We need to be very clear about what happens to these patients. A lot of my patients are living longer, which is great. And what we're doing or what we're picking up is other cancers developing in GIST patients. Or patients may have a previous diagnosis of cancer. Somebody may have a breast cancer in the past or a bowel cancer in the past, now develops a GIST. No link between the two, but they're developing. And also, GIST picked up during the investigation for another cancer. For example, stomach cancer, they had a gastrectomy and pick up a GIST. Or bowel cancer, they had a CT scan, the small GIST sitting there in the stomach. Or other cancers developing while on follow-up for GIST treatment. For example, patient has a tumor resected, a GIST resected, say 10 years ago, and metastatic disease on imatinib or sunitinib, other cancers developing. And we need to be aware of these things because they have very, very important diagnostic and therapeutic treatment decisions to be made. You should not assume that somebody developing a new metastasis while they're on imatinib, if there's another cancer sitting somewhere else, or they had a previous history of cancer, do not assume that this is due to GIST, and probably want to biopsy it. And what we don't know is it purely a coincidence that this is happening because our GIST patients are living longer, or are they part of a multi-tumor syndrome? What cancers are we seeing? We're certainly seeing prostate cancer, higher incidence than expected. And we are seeing lymphomas, And breast cancer, maybe coincidence. We got one patient with chronic myeloid leukemia and GIST, CML and GIST, and she's having imatinib for CML, which would sort out her GIST as well. Then we have rare associations. We have a patient with soft tissue sarcoma, GIST at the same time. We got patients with neuroendocrine tumors like carcinoid tumors, which are old-fashioned term for neuroendocrine tumors, and GIST. Is that a syndrome? We got one patient with male breast cancer. Breast cancer in males is extremely rare. And we got a male breast cancer plus a GIST in the same patient. We don't know what this link is. I've just reviewed a paper from the American SEER database. SEER is the epidemiology database in America. And they looked through the last 10 years of GIST incidents in America, and that paper is going to be published in one of the big American journals, I think in about 3 months' time. And they have seen the same pattern. There's a higher incidence of cancers in patients with GIST. Quite a lot of it, the proposition is that it's coincidental because GIST patients are living longer, and also, as it is, there are other cancers that are going to happen in that age group anyway. But we need to be aware that this is an important issue for GIST patients. And also we need to be careful about putting labels on GIST patients when they have other cancers. I'm going to use the Cambridge model, which I think is probably similar in most of the other regional centers. The benefits of the specialist MDT, especially in rare cancers. I am a firm believer in centralization of rare cancers. I think I might be politically incorrect if I say that we should not allow patients to be seen in a DGH or a small cancer center, but that's my view. They should be seen in a multidisciplinary team in a bigger cancer center. If it happens to be 80 miles away, so be it. They should be seen there, but not in small, because I work between Cambridge and Bedford. Bedford is small DGH. I treat other cancers as well, but I do not see my GIST patients in Bedford. No, they come to Cambridge. They might be living 2 minutes away from the hospital in Bedford, but I don't see them. They come to Cambridge to the clinic. So histopathology, surgery, and radiology, what are the benefits? Oncology, the expertise in the natural history. Very, very clear. I need to be one step ahead of the tumor. I need to predict what's going to happen to this patient in 3 months' time, 6 months' time. If I'm going to do a scan in 6 months, I need to be confident myself that I have cleared about what I can predict for this tumor. I couldn't have done that in 2004. Now, most of the time, I can say, yeah, okay, fair enough. I won't see you for 6 months. But there are patients who I watch like a hawk. I don't want to leave them for more than 2 months or 3 months. I'm just paranoid because something in my mind says, not sure about this. So that experience is very important. And an experience in managing drug toxicities. We need to be very clear that some of the drugs we're using are quite toxic, especially the second and third line therapies. And how you get on and how you manage the drug toxicity is very, very important. And again, you need to be one step ahead of the drug before it causes toxicity. Sometimes we can't, but we need to be very clear. Radiotherapy, clinical trials, and the key player in this is your nurse specialist. If you do not have a good nurse specialist, or if you don't have one, you shouldn't be treating GISTs. You need to be very, very clear. And the problem is we don't have enough of them. That's the problem. There's one person managing the whole of the sarcoma service in our hospital. How can that be? We need 2, maybe 3, or maybe 4. But that's reality. And the specialist palliative care. This looks complex, but this is what happens in Cambridge. So when the patient comes with a diagnosis of GIST, promptly to upper GI, because that's where they sit, or hepatopancreatibiliary, or occasionally colorectal. And we had some women who came through gynae MDT because they had omental disease, peritoneal disease, and presumed gynae cancer. And there are patients who came through cancer non-primary. They didn't have a primary GIST diagnosis, but they had metastatic disease. So came through that. So we have a central histology review, and they come to the GIST clinic for consultation, and they go through different pathways. If we got a primary inoperable GIST, we start them on imatinib, do the mutational analysis, start them on imatinib, and if the tumor shrinks, they go back to the surgeons for a resection. And in the high-risk patients, they go on to adjuvant imatinib, And I made it mandatory. I mean, mandatory means mandatory, that they will have their mutational analysis done before going on adjuvant imatinib. We would not treat patients on adjuvant imatinib without doing mutational analysis. And then clinical trials. And the metastatic patients, they go on imatinib and sunitinib. And then we think about possibly surgical resections in metastatic disease. Just need to be careful because evidence is not there as yet, but a lot of us are doing it. Just to give you some idea about the specialist pathology, Philippe, apologize. I'm wearing a pathology hat now. Sorry. Right, so one take-home message is that majority of the GIST patients, the tumor actually is outside the stomach. You turn out to see much of, we may see an ulcer in the stomach, but nothing much. And often say, oh, endoscopic biopsies are negative. They're 99% of the time. We only had 2 patients in the last 10 years where the endoscopic biopsies, ordinary biopsies, were positive, showed tumor cells. Majority of the times, endoscopic biopsies are negative in GIST patients because tumor is sitting underneath the mucosa. Okay, so this is a big tumor sitting there, and it's a spindle cell tumor, high mitotic index, and this is where we want to have a think about when do we think of GISTs. So any kind of a spindle cell tumor in that area. And the differential diagnosis is the other smooth muscle tumors like leiomyosarcoma. We had 2 schwannomas in the last month. We haven't seen them for about 5 years. And then inflammatory myofibroblastic tumors. And you always remember this guy, melanoma, been caught out twice in the last 10 years where the melanoma was mimicking a GIST. It was KIT positive, but luckily it was DOG1 negative. We knew it wasn't a melanoma, but just to be aware that melanoma can mimic a lot of tumors. So this is our panel at the moment. KIT CD117, that is the standard. And then we have DOG1, Desmin. We kind of coned down now. We're not doing that many immunos. KIT, DOG1, and Desmin. And we sometimes stop there. We don't really worry about doing too many immunohistochemistries. And DOG1 is that discovered on GIST. That's what stands for DOG. Somebody had a fantastic sense of humor there, KIT and DOG. So this is something has made the diagnosis much more robust. So what we do is we review the histology centrally and immunohistochemical panel including DOG1, the risk stratification of the tumor, mutational analysis kindly through Birmingham, Philippe, and the final histology report summarizing the risk stratification and the mutational status. So what it tells us is 12 centimeter tumor, DOG1 KIT positive, Desmin negative, or not resection and high risk. And this is the problem. Who does it? Who pays for it? And I certainly feel that it's mandatory in the adjuvant setting. And we know that it is predictive value. We know that there's some prognostic value as well, but it's not been incorporated into the routine day-to-day risk stratification. So mutational analysis is quite useful to predict the prognosis, but has not been incorporated into the day-to-day use. And in the wild type GIST, meaning when the tumor does not have a KIT or PDGF alpha mutations, then we go down the route of doing something else extra as well. Now, there's one thing you need to be very clear. The mimics, lots of tumors can mimic GISTs, both radiologically and also histologically. As I said before, we've been caught out quite a few times. You wouldn't know. I could easily sell to anybody that has a GIST, but it was a melanoma with a metastases. This was a gastric adenocarcinoma. Looks like a GIST because most of it actually outside the stomach. And this one is a gentleman with a leiomyosarcoma, but initially reported as a GIST by an outside pathologist and started imatinib for 6 weeks and then came to us, and in fact Philippe did the mutational analysis and informed me saying that this little one got wild type GIST. I said, no, can't be. Went back and looked at it. It was DOG1 negative and it was leiomyosarcoma. So from a GIST to leiomyosarcoma was a big jump in the diagnosis and the prognosis. And my message is, please do not use the G word without a central histology review. Never ever tell the patient that patient is got a GIST based on radiology until you have the full histological review by an experienced GIST pathologist. Very, very clear. Specialist surgery, we do quite a lot of surgery through laparoscopic excision, and we got 3 GIST surgeons who can do that. So they all come to the GIST MDT, and we don't routinely biopsy them preoperatively. So we don't actually biopsy them. If you're not going to give them imatinib preoperative, we don't biopsy them. If it's operable, surgeon says I can take it out, take it out. As simple as that. So laparoscopic excision. And this one is very, very important because this is where you see the benefit of the multidisciplinary MDT. So this lady came along with abdominal pain, anemia, and large abdominal mass on examination, and CT confirmed the same. And the concern was that she would require multi-organ resection. And the whole of the gray bit is tumor. And that is on that side. This is the spleen. That's all tumor. And that was what the surgeon said I had to do: total gastrectomy, splenectomy, transverse colectomy, partial pancreatectomy to get a clear margin negative resection. And the recommendation was to commence on imatinib. Before commencing imatinib, we did an endoscopic ultrasound guided biopsy, confirmed that it's definitely a GIST, and also got the mutational analysis done to make sure that this tumor has got imatinib sensitive mutation. So if I'm starting a patient on preoperative imatinib, now I would never start imatinib without knowing the mutational status. That's very, very important. Blindly, I wouldn't start. We would have done it back in 2008, 2005, 2006, but not now. So this patient had imatinib at baseline, 3 months, 9 months on imatinib. You can see how tumor shrunk quite nicely. And what she then had was sleeve gastrectomy, that's just part of the stomach removed. And the spleen had to be removed because the tumor was stuck to the spleen. But that's it. So she finished 3 years of adjuvant imatinib and ongoing complete remission on CT. We saw her about April 2014. She's come back in I think she's come back in October. So again, the important thing is multidisciplinary discussion of this patient's management to make sure that she gets the right sequence of interventions. Specialist radiologist, and again, we learned quite a lot in the last 10 years. Just sit under the submucosa, in the submucosal layers. But there are other tumors which sit in the submucosal layers as well. For example, lipomas, neuroendocrine tumors. Pancreatic nest, it's not a tumor, it's just a anatomical aberration which mimics a lump. And then they very rarely granulosa cell tumors. And you need to know how they look like under the endoscopic ultrasound. Nick Carroll, he's our endoscopic ultrasound radiologist. He's also the cross-sectional imaging radiologist. And we've got 2 others who have joined the team. So that's a typical GIST. And this is a duodenal neuroendocrine tumor. And there's a lipoma, which are very bright areas on the endoscopic ultrasound. So suspected GIST diagnosis is not a definitive GIST. Always need tissue. At the end of the day, you need to have the tissue to make a diagnosis. Just because somebody says it's a GIST, it's not a GIST. And experienced endoscopic ultrasound radiologist can give you tissue. Decent course, you can make a diagnosis of GIST staining with CD117 dog1, and also you can do mutational analysis on that limited sample. If you got enough cells there, Philip and other molecular pathologists will say, yeah, I can handle that if you got enough core. This is something we learned in the last 10 years. Again, goes back to the expertise and experience. You need to be very careful when you're assessing response. Ignore that bit. Baseline pre-imatinib, post-imatinib, very happy. Tumor shrunk, big mass, gone to the small. This one patient, unfortunately, on imatinib, but 30 months, you can see there's increase in tumor size. This is a long time ago. There's no problem with that. What about this one? The tumor is sitting there in the top left-hand corner of your slice there, above the black bit. And that was baseline, and this is after 3 months. It's actually got bigger. But look at the density of the tumor. Density has gone down. So again, we learned that size does not matter in patients with GIST patients on imatinib or sunitinib. And it was PD as per the RECIST criteria, because RECIST says size. And same thing with this. Tumor has not changed much in size-wise over a 12-month period, but you can see what has happened. It's become darker. And the density has gone down quite dramatically, from 38 Hounsfield's units to 12 Hounsfield's units. And this gentleman actually had a resection done in 2004. So Hosen Choi, who is a radiologist in MD Anderson, Texas, she proposed this criteria using both size and density. And difficult to do it routinely, but in a specialist environment, we should be doing it, and we do it in patients where there's uncertainty with regards to the response. However, if you have problems, somebody with a calcification, the white blob there is a calcification. That makes the density very high. This gentleman had blood into the tumor in the liver, and this one actually perforated into the stomach. So there's a connection between the stomach and the tumor. So if you have these kind of problems, sometimes the density criteria may not be useful. Now, more importantly, in the NHS setting, it's time consuming to try and work out the density and everything. What we do is straightforward response. We don't bother with densities. But any uncertainty before making a decision about do we stop the imatinib or sunitinib, we do use the criteria to try and work out, is it really true progression? So the same thing happens with sunitinib. So this was a paper from Peter Reichardt's group. This is an example of why you have to be careful about the size. Patient on sunitinib, baseline, gastric GIST, multiple liver metastases, 3 months, slowly getting bigger, 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 bigger. But the density was so low compared to that. We carried on, 15 months, carried on with the sunitinib, despite the radiologists locally reporting this as a increase in size. Again, same thing, multiple liver metastases, and then you start seeing some new lesions developing in that area, in the liver. And then you have to ask yourself, are these new lesions new metastases? They're not. They are there before. They become hypodense, become darker. They're more easily visible. So again, if you haven't got the experience in actually looking at these things, you would run into problems by calling this falsely as a progression, stopping the drug. So role of oncologist, I've said before, experience with the drug and the disease. I'm going to skip this one. I'm just going to say this is a patient who has a high risk GIST, and this is the stratification we're using for patients who have had the primary tumors resected. At the moment, we're using the maintenance risk stratification, looking at the tumor site, tumor size, and the mitosis. The ones in the red are the ones we categorize as high risk. Ones in the yellow or possibly the intermediate risk, and ones in the green or the low risk. So if you have a patient with a tumor, you need to know these 3 parameters. So the size of the tumor, the site of the tumor, and the mutational and the mitotic index.
Ramesh, can you explain what the risk is of?
The risk is of the tumor coming back. So risk of relapse. So when the primary tumor has been removed, you have to stratify the risk of the tumor coming back in the next 5, 10, 15, 20 years. So you need to work out in your own mind, also the patients as well. So what would happen to me when this tumor is removed? What are the chances of this tumor coming back? And the chance of the tumor coming back are based on these 3 parameters. In the other cancers, we use what is called TNM, tumor node metastasis system. And tumor and node are the ones which tell us how aggressive the tumor is and what are the chances of the tumor coming back. In the GIST world, though there is a TNM system already there, none of us use it routinely. We use it for coding purposes, but not routinely for working out the risk of the tumor coming back after the primary GIST being removed. So in that setting, you need to know the size of the tumor, the site of the tumor, and the mitotic index. And I may dare add the mutational status as well, but it's not as yet become standard. There are other nomograms which have been developed in other parts of the world. And Heikki Jonsson, who is one of the top GIST oncologists in Europe and the world, he has developed this what's called contour maps. The hotter it is, the higher the risk, based on, again, the mitotic count, size of the tumor, site of the tumor, and also he had a rupture as part of the equation. So the prognostic contour maps give you a prediction of the risk of the tumor coming back in the next 5-10 years. This is, again, not as it becomes standard, because it looks a bit confusing and a bit difficult to understand, whereas this one, much more easy to understand, because you got a nice table there telling you what are the risks of this tumor coming back in the next 5-10 years. So why do we need this? We need this because we want to discuss with the patients the risk of relapse and counsel them for the same, and also, equally importantly, to determine the frequency and the intensity of follow-up consultations and imaging. If somebody has got a 1.6% risk of relapse from a tumor which has been removed, I wouldn't really worry about scanning them 3 monthly, 6 monthly. I wouldn't bother, because the risk of relapse is so low. Counsel them, have a discussion in the GIST clinic, and sometimes we say goodbye. You don't have to come back and see me. But somebody's got a 10 centimeter tumor in the small bowel, 8 mitosis, the risk of relapse is between 50 and 80%. They need regular follow-up because it's high risk of relapse. This is prior to the adjuvant imatinib. Now, in 2014, we see these patients and we discuss the adjuvant imatinib with them. And what is the evidence based on? Based on, most importantly, this trial, the SSG 18 trial, Heikki Jonsson's trial, where he used high-risk patients and randomized them between 12 months and 36 months of adjuvant imatinib. So these were the patients who were included in the German Scandinavian trial. So histological confirmed GIST, tumor more than 10 centimeters, or high mitosis, or tumor rupture. And what was very clear was that patients who had 36 months of imatinib, which is yellow, did much better than the patients who had 12 months of imatinib after the primary tumor was removed in that high-risk setting, and the difference was statistically significant. And more importantly, the overall survival was different as well, 10% difference in the overall survival. And you have to compare that benefit with other cancers. For example, if you have breast cancer and you have Herceptin, which is one of the standard treatment for breast cancer, the extra benefit is 2%. When you have lung cancer, you give adjuvant chemotherapy after the operation for lung cancer, extra benefit is 4%. So it's actually much better than what we've seen in other solid tumors. Other important thing is that almost everybody benefited, and there were some issues about wild-type GIST patients, but numbers were very small. And so if you're on that side of the curve, it's something that you've got a benefit. This means no benefit for extra 36 months. So it looks like everybody benefited from the adjuvant. So what we do now in Cambridge is that we made it mandatory to have the mutation analysis done before adjuvant imatinib, because we know that about 20% of our patients have either wild type or a resistant mutation. And this is now the new standard of care, and NICE has just said yes to adjuvant imatinib earlier this month. So adjuvant imatinib is now available through NICE. Prior to that, it was available through Cancer Drug Fund. Goes back to that statement I made in the mutation analysis is mandatory before you commence adjuvant imatinib. It costs about, I won't say the cost. No. But if you avoid one patient with the resistant mutation or a patient you're not likely to give the adjuvant imatinib, you can fund all your mutational testing by avoiding that one adjuvant imatinib for 3 years. For the rest of my life, I can fund it. That's how I look at it. But the managers don't look at it that way, but that's reality. I can actually simply, by avoiding one patient having adjuvant imatinib, I can fund my whole mutational analysis for the next 5-10 years, quite happily. So this patient actually had adjuvant imatinib, and she's now completely well, ongoing, no evidence of recurrent disease. Just saw her in September. Second line sunitinib, we got the data from George Dimitri. This is one of the sad stories what happened in this country. Again, politically incorrect statement. Drug license in 2006, rare cancer, significant benefit based on PFS. Overall survival was not different because there's a crossover. And NICE took 3 years to actually to approve the drug. And lots of my patients, when I was back in 2006, we used to get what we call IFR, individual funding request, begging the PCTs to give me the drug, literally begging. So it took 3 years. And sunitinib safety profile, it's a completely different drug. It's a multi-targeted tyrosine kinase inhibitor, so it's not a clean drug in the old-fashioned way, an effective drug, but we need to be much more careful. Mucositis, diarrhea, hypertension, skin discoloration, fatigue, the most common side effects. And same thing happens in the populations from Poland as well. What they've shown is that if you develop hypertension, you tend to have a better survival. This is one of the biological markers for sunitinib. The dose is 50 milligrams, 4 weeks on, 2 weeks off. We have moved on to 37.5 milligrams continuous daily dosing because we find it difficult. What I've learned in the last 6-7 years since been using sunitinib is try and maintain a dose which the patient can tolerate. Doesn't matter what the dose is. It could be 25, it could be 37.5, it could be 50. Some of the patients take Monday to Friday, they take Saturday, Sunday off. It's not in the books. Nobody actually, we just made it up. But did we make up because we knew more than the trials? No, it wasn't. That's what the patient could handle. They could not handle the whole 7 days of sunitinib, and they felt better having those 2 days off. There are patients who are comfortable taking 50 milligrams of sunitinib for 4 weeks on, 2 weeks off. They're very happy with it. They actually prefer having 2 weeks of drug-free period. Again, that depends upon how you interact with the patient and the family, what they want to get out of you and what you want to get out of them. And this is a dialogue you need to have. Sit down, and you need time for these things. You can't rush the consultation. That's why my GIST clinic, I have a clinic from 9 till 1. I tend not to see more than 4 or 5 patients. Sometimes it runs until 2 o'clock, but every patient gets adequate time based on their parameters, not my time. I don't do these things. So they get the time, and we need to sit down and actually see what they want out of the consultation and try and maintain a dose of the sunitinib and personalize the schedule to the patient. And also be a bit more proactive, because we had a fairly easy ride on imatinib for a number of months. Yeah, take a drug, go away kind of thing. Then you change to sunitinib, you just need to be extra careful. And the final message with both sunitinib and regorafenib is work with the drug, don't blame it. Because we got limited lines of therapy. That's another reason why. This is Beatrice Redden's paper, just looking at the survival of patients who've been on sunitinib in the real life. It looks better than the published data. The flexible dosing schedule patients tend to do better. And also, the fitter you are, more likely that you got better benefit out of sunitinib. So that's another thing we need to learn very quickly, that you don't want to drag on with the imatinib for too long and make the patient more ill. If they're clearly progressing, the answer is switch. So this is the flexible dosing. This is the strict starting schedule, and they tend to do better from the real life data. Ignore that one. Ignore that one. Lots of patients ask me about, can we actually biopsy the tumor again? The tumor is progressing on imatinib. Can we stick a needle into the tumor and actually biopsy it, find out what these mutations are? Because over a period of time, when the drug stops working, that means there's a resistance developing for the drug. And in the old days, what we used to say is that this is a secondary resistance under the pressure of the tyrosine kinase inhibitors. That's what we used to say. What we know now is that these things were already there at the beginning, and over a period of time, we killed the sensitive cells, and the resistant cells are actually multiplying now. Can we take biopsies of the tumors and find out what resistance it is, what secondary mutation? And what we've learned is that these are the secondary mutations which develop. Some of them are sensitive to sunitinib, the ones in the green. The ones in the red are resistant to imatinib, and ones in the yellow are intermediate. That means quite a few of them are not sensitive to sunitinib. The problem is this: there is a heterogeneity, meaning there's a difference in where the mutation resistance happen. If you take a tumor from the right lobe of the liver, it will have a different secondary mutation. If you take a tumor from the left lobe of the liver, it will have a different secondary mutation. Within the tumor, north, east, west, south, take biopsies from 4 quadrants, you have different secondary mutations within the same lesion. So there's what we call as intralesional heterogeneity. So that's the reason why we do not routinely recommend taking biopsies after a patient has progressed on imatinib, so that it doesn't guide the clinical practice. Not yet. So the guidelines are very clear, both the American guidelines, the European guidelines, and our guidelines, no routine recommendation for secondary mutation testing in the clinical setting. On a research side, that doesn't matter. Life beyond sunitinib, yes, there is. Regorafenib, George Dimitri's paper from 2012, and there's a very clear median progression-free survival of nearly about 5 months. Side effects are fairly similar. Hand-foot syndrome is a common, hypertension, diarrhea, fatigue. These are the common side effects. And what is interesting is that the subgroup analysis have shown that male, female, age, younger, older, how long you've been on imatinib prior to, how long you've been on sunitinib prior to, they all benefited. If you look at the hazard ratios, they're all pretty good. So it looks like it doesn't really matter what you have had before. There's a reasonably good chance of responding to regorafenib. George Dimitri also highlighted some interesting technical advances based on the trial. What he did was this concept of liquid biopsies, meaning that you take the plasma and look at the circulating free DNA, not tumor cells, circulating free DNA in the plasma, and compare that to the tumor DNA. And good thing was that the primary mutations were similar. That means there was circulating DNA from the tumor in the plasma, which they could pick up based on this technology. But they could pick up more secondary mutations in the plasma than they could do from the tumor biopsies, which was interesting. It's just watch the space, because this is something completely new, not as yet become standard practice. In fact, the technology is not in the clinic anyway. But very, very interesting, because you could actually take a plasma sample and work out what the secondary mutations are. So I'm going to stop there. I'm happy to take questions now, or I want to just to give a quick update on the PAWS GIST clinic. Are you happy with that?
Yeah.
Because I'm happy to stay here longer, as long as I leave by 1 o'clock. I need to catch a train and then flight. I just want to give a quick update of what has happened with the pediatric wild type clinic in UK. So that stands for PAWS, stands for Pediatric Adolescent Wild Type Syndromic GIST. And as all good things, idea was born in a pub in Oxford. I think Judith Robinson will remember very clearly the Marston old Victoria pub, and a few beers, and it was a wine, I think, not beer. But it was a very important meeting we had, because that's where we thought maybe we should do something about this rare subtype of GIST. So what do we mean by the wild type GIST? There are no activating mutations in KIT or PDs alpha. We don't routinely test exon 8, but Philip has got views about that. What about BRAF? We need to be testing that as well. And the Italians come up with a triple negative, quadruple negative GIST. For example, no mutations in KIT, no mutations in PDGF alpha, HTS deficient, BRAF is wild type. So you can actually pick and choose. We are comfortable with the PAWS concept because it encompasses wide, complete range of the tumors, which though heterogeneous quite by definition, but gives an idea about what they are, pediatric, adolescent, wild type, syndromic. So we're comfortable with the PAWS gist. So we knew back in 2010, 2011, when we met, that Americans have had a clinic for a while. They had this consortium called CPGR, the Pediatric Wild Type Gist Research Consortium, and they have been doing these clinics twice a year since 2008. And they have actually generated a lot of data. They had about 95, about 100 patients. That was a small number for a country the size of America. And they come up with this. You don't have to go through the whole lot. One thing they've said is that these two, group B and C, are the ones which seems to be very different to group A. And the group B, if you just look at the top one, hypermethylated, that seems to be the thing. There's something about their DNA. It's not they got a genetic defect within the gene, but something outside the gene on the top, which is seemed to regulate how the gene functions. That's been upset, or that's been damaged, or that's been deficient, and that's how they develop the tumors. What is peculiar to these patients is that they're predominantly women, young women, and predominantly gastric, and often multifocal. So we set up a focus group, and Jane has been in the forefront of this since the inception, started fundraising, and we also felt that there should be European Clinical and Research Consortium. We had a first meeting back in October 2013, almost to the date, in London, and we started developing a website, and we made plans towards a national clinic for this rare subgroup. And the plan was to raise awareness and interact with healthcare professionals, patients and carers, and also the pharmaceutical industries. And the whole theme was to coordinate, collaborate, and engage. Discussions with basic science, translational groups, National Tissue Bank team, and also at the time, we did have discussions with Professor Michael Richards. He moved on to something else. So progress so far. Jane will probably update you on some of this. So we have a tumor bank. The UK GIST registry is now merged with the Encore, which is the England Cancer Registry. The PAWS GIST website gone live in February 2014. We had 2 clinics held so far in Cambridge. So that's what the website looks like. It gives some information about what PAWS GIST is, and the clinic, the aim of the clinic, benefits, how to register. So there's a form we can register. You just press the submit button, it comes straight to me. And also you can contact for any just inquiries, putting your email details, etc. And we're trying to populate this for the healthcare professionals, extra papers and etc. So those things. Support from Just Support UK, Sarcoma UK, Sarcoma Patient European Network, and Rare Cancers Europe, and Macmillan. So the concept was to make it happen was, it's actually you guys, nothing to do with me. It's the patients and the carers. They wanted to happen, and it's happened. If there was no drive from the patients and the carers, this wouldn't have happened. And Judy has been a strong support from day one. Without her enthusiasm and help and pushing me, in fact, first person is Jane. In fact, if you look at my thing, about 90% of my emails are from Jane Bressington. 99%. Again, Just Support UK have been instrumental in actually driving this through the PAWS GIST, the charity. Without the Just Support UK, without the Sarcoma UK, we wouldn't have been here. And Sarcoma Patient European Network have been very, very helpful and very supportive. And senior colleagues, Ian Judson, Mike Lee, Beatrice Seddon, they have been helpful in writing the standard operative procedures, and but the fundraisers as well. So that's the website, pawsgistclinic.org.uk. So what do we have so far? 18 patients registered, 16 women, only 2 men. So that shows how strongly female dominant this tumor is, and majority of the tumors on the stomach. We had 1 patient with stomach and small bowel, but majority of the stomach. And the first clinic we had in March, second in August. We have a pre-clinic get-together the evening before. They get reviewed in the clinics, and they get the genetic testing done through Professor Mayer, who is the clinical genetics professor in Cambridge. And we have time to answer any questions from the patient and the families. One thing which I have to admit, and I failed miserably, which goes back to the way we function in NHS, is the communication side of things. And I need to put my hand up for that. This is one thing I need to improve. So this is where the patients are coming from: Aberdeen, Newcastle, Manchester, Liverpool area, Sheffield, Bristol, Birmingham, London. So all over UK. We have already complaints from the NHS England that why am I seeing patients from Scotland and Wales? Who's paying for them? So the bureaucracy. Despite this being the only clinic in the whole of Europe, this is the only second clinic in the whole world and the only clinic in the whole of Europe, and there are already complaints from the managers. So what have we learned so far? It's more heterogeneous than we thought. We thought all wild type just the same. One group, but they're not. They're very, very different. That's the first thing we learned. It confirmed the female preponderance. Again, median age is much, much younger than your average GIST patients in the sporadic mutated GIST. That's another thing we learned. And talking to these patients, we come to know that imatinib doesn't work very well in these patients. So maybe we shouldn't be using it, but we are mandated to use it because imatinib is a first-line therapy and sunitinib is not licensed for first line. So unless you're intolerant or you progress, so that means you spend a lot of time using a drug which is not very helpful. Certainly these to be more active. And other thing is we need to have much more collaborative approach. So what is happening? Research scenarios which apply to, some of these apply to the mutated GIST as well. We've been obsessed with developing cell lines, and Jane again has been instrumental in coordinating the efforts between various molecular pathologists and researchers to guide fresh tissue straight from the operating table in ice into a laboratory in Sheffield, Marsden, and Bethesda near Washington, D.C., FedExed from the operating table to there. So we've got 3 patients, 3, sir? 4. 4 so far, tumor samples collected fresh from the table, operating table, into the lab to try and grow cell lines.
It's really important that we get advance warning of any wild-type patient who's about to have an operation, particularly for this project, purely because we need to capture the wild-type tissue. It's not just to go to the bank, it does go to the bank, but it also needs to get to the researchers in a very short space of time for them to be able to use it to try and grow these cell lines and xenografts.
Yep. Now, we've been using KIT-targeted therapy for over 10 years now, so everything revolves around KIT. So that means you have imatinib, which is the KIT inhibitor, sunitinib, KIT inhibitor, but also inhibits other kinases, regorafenib, KIT inhibitor, but also inhibits other kinases. Knowing now what we know with the wild type, just that they don't respond very well to imatinib, but may respond to sunitinib or regorafenib, is it time to think about completely going back to the drawing board and wipe off the slate clean kind of thing and say we want to start from scratch? And that's what some people are doing. And what we have is in patients who have wild type GIST, whose tumors are succinate dehydrogenase deficient, that is SDH deficient, there may be a different way of targeting. And also, we have been talking to some colleagues in Germany who are looking at targeting the cell cycle kinases. And we just had an email just about 3 days ago, about this trial in America. We're looking at this targeting the enzyme called glutaminase, which is an interesting enzyme. And perhaps maybe there is some mileage in these things. Just to take you through this, looks complex but fairly simple. This is a slide of a patient who has got a succinate dehydrogenase deficiency. And what happens is, if you have a succinate dehydrogenase deficiency, which is an enzyme in the Krebs citric acid cycle, if you need to go back to your biology, A-level biology. So the Krebs citric acid cycle is the one which is the aerobic and anaerobic cycle for your glucose metabolism. So if you got the SDH intact, succinate is converted into fumarate and then goes down the cycle. But if you're deficient in the SDH, the succinate from mitochondria, which are actually inside the cell, it leaks into the cytoplasm, which is outside the mitochondria, outside the nucleus. And then what it does is it blocks this enzyme called PHD, prolyl hydroxylase, which normally helps to knock out this HIF1 alpha. What does HIF1 alpha stand for? Hypoxia inducible factor 1 alpha. That means it is a kind of thing which is there in the cell, which is triggered on hypoxia, where their oxygen levels are low in the tumor cells or in the normal cells. It's only triggered then. Normally it is destroyed or inactivated very quickly. If that enzyme is actually knocked out, HIF1 alpha goes into the nucleus and starts activating lots of things, especially the various genes which are involved in proliferation, angiogenesis, survival, etc. So what happens is, the end result is cell growth, multiplication. So one of the hypotheses in patients with SDH deficient GIST is that if you're deficient in SDH, the succinate comes from the mitochondria. Normally, it always sits in the mitochondria. It never goes out of the mitochondria in normal cells, never, ever. It leaks into the cytosol and then creates this problem with the HIF alpha being there, not being inactivated. And this causes the tumor to multiply. Can we switch off any of these? There's a drug which can act around here, being tested in other cancers, not in GIST as yet. We asked the question, can we actually push the succinate back into the mitochondria? Why can't we do that? I just shove it. No, absolutely can't. It's not that easy. But work has been done at the Beachton in Glasgow in cell lines where they have managed to have a permeable form of alpha ketoglutarate, which is one of the other amino acids, which actually been pushed, able to push succinate back into the mitochondria. It was done in vitro, but not in vivo. We did not have a human usable form of alpha ketoglutarate. So we've talked to Cancer Research UK. Initial thing is, can't be done, but watch the space again. So
We need cell lines.
that's the reason why we need cell lines. Okay, yep, that's true. So this is complex, but the simple thing is that there is one single thing wrong with these cells, which is that the succinate should be sitting in the mitochondria, leaks into the cytoplasm, and then causes the problems here. So somehow if you can actually work it out, because I'm not a scientist, I'm a clinician. I only got one brain cell, and that talks about GIST all the time, So I think I need somebody to try and help me to try and work out. And this is about the CDK inhibitors I talked about, cyclin-dependent kinase inhibitor, which inhibit the cell cycle. And that's the resting phase. All the cells start from G0, G1, DNA synthesis, which is S, G2, and then mitosis, which is division, cell division. So there are certain cyclin-dependent kinases which are upregulated or mutated in GIST, and one of them actually is CDK4. And again, we knew about this about 2007. There's a guy called Florian Haller. He's a molecular pathologist in Germany, Erlangen in Germany. He's done some work in 2007 and got published and moved on. That we know now that there's a drug, it's first of its compounds in this class, palbociclib, which is a Pfizer compound, which has been fast-tracked for breast cancer by the FDA, and it may work in GISTs. And the problem is there are no trials as yet. The French are doing a trial in patients with mutated GIST, not in wild type, in mutated GIST in the adult population, patients who have progressed on imatinib and sunitinib, they want to test out this drug. But there are strict entry criteria. You want to have the tumor sample, you want to test for the CDK4, obviously you need to know that that's actually mutated, and also they want to test for other things as well. There's a protein called PRB, retinoblastoma protein. There's something called P53. There's something called P16. So they want to test for lots of other things in the tumor cells to make sure that the tumor profile fits in with the drug which they want to use. So this could be something, again, watch space. I talked about glutaminase. Again, we got a familiar friends here, the Krebs citric acid cycle. See how we are moving away from the KIT. We're not talking about KIT anymore, or the PDGF alpha. We're moving completely away from what we've been talking about last 10 years. So we got the same friends, succinate, we talked about it before, fumarate, we talked about before. Now, we're just moving one step before that. The glutamine is there in all cells. It so happens that cancer cells take up more glutamine for their metabolism compared to normal cells. And glutamine is converted to glutamate by this enzyme called glutaminase. And the glutamate goes into the mitochondria and helps to drive the Krebs citric acid cycle in the cancer cell. And surprise, surprise, whenever you have that kind of a thing, they have actually developed an inhibitor for glutamate called CB839, which is undergoing trials in GIST at the moment. Not just GIST, various cancers, solid tumors. GIST happened to be one of them. And specifically, they're targeting SDH deficient GISTs. And this trial is a phase 1 trial in America. The company is a small company. The problem with these drugs is that they're often manufactured by tiny companies, 3 people, a chief executive, chief operating officer, and a scientist. That's it. And they're often taken over by the bigger companies when the drug shows some activity. So that's how it happens. So the trial is happening as we speak in North America. Looks very interesting, very promising, because it does not depend upon the KIT or the PDGFR alpha. So it looks like the next generation of drugs which we're going to see may not be anything to do with the drugs we have used in the last 10 years, the KIT-driven or KIT-targeted drugs. So what's next? Jane will update on the tissue bank, cell lines, xenografts in progress. We've been talking to various pharmaceutical companies, both the national level and also international level. We have a meeting with Ariad about a drug called ponatinib, which has been used in GISTs, and there is some activity. And hopefully that drug should be coming into market very soon. The head-banging sessions with scientists. I've been driving everywhere with Jane, Oxford, Bristol, Glasgow, Cambridge. And we got links with Japan through Oxford, looking at the metabolomic, meaning the things I talked about, the Krebs cycle and all these things. So we're going to send the tissues to Japan because the guy is already doing some work there, which we didn't want to duplicate here. So the tissue is going to go to Japan to look at this specific issue about the Krebs citric acid pathway and the metabolomics of the tumor cells. And hopefully, a clinical study, a clinical trial at some point in the near future. I'm going to stop there. I want to say this. Most of the work so far is free, on goodwill, on time. All of us, Philippe, myself, Ian Judson, anybody, talk to anybody. We are passionate about this tumor. We're passionate about looking after our patients. We are actually obsessed, and we want to do the best for our patients. More treatments, better treatments, easily manageable treatments. Improve the QOL. For me, QOL doesn't mean quality. It means both quality and quantity. Okay, so improve and possibly cure one day. Maybe, not very distant future. Maybe I'm on a Zimmer frame, but I will see it, What we feel is that the only way we can achieve this is to have the right resources and the right type of people and the right kind of backing from the Department of Health and the government. If you can achieve some kind of a specialist status, specialist commissioning status, maybe that will change the way I work, because post-GIST is 1% of my workload. 1% of my workload is post-GIST. And GIST as a whole is 10% of my workload. So I got 90% of my patients who have got no GIST. They got lung cancer, bowel cancer, pancreatic cancer, stomach cancer, lymphomas, unknown primaries. So I look after those patients, plus anything extra I do is in my own time, on a Saturday, Sunday, middle of the night, emails to patients, that kind of thing. Happy to do that. All of us are very happy. I've seen Ian Judson emailing me at over 2 o'clock in the morning. What are you doing? But what am I doing at 2 o'clock in the morning in front of my computer, But we do it. If we have a formal structure within the NHS for this rare cancer, not just GIST, rare cancers as a whole, we need to have that kind of thing, that rare cancers treated in specialist centers, and they have the adequate support, both the financial, the resources as far as healthcare professionals concerned, and also support staff as well. Charlie, who runs the GIST, wild-type GIST clinic, he's as important as me. He just runs the clinic, he just sits on the desk, but he's as important as I am in the clinic. So without him, I won't survive. So Charlie, the guy who does the clinic receptionist job, is a very, very important person. So I need those kind of things set up for me to function properly. And that's where I feel that though all of us are happy to do these things, all of us are happy to support the patients and give the best we can for the patients, we need a formal structure within the NHS, within the Department of Health, for us to function effectively, to get the best out of us, for the better care for the future. I'll stop there.
Well, thank you very much, Ramesh. I feel a bit mind blown. It's all very exciting, and obviously things are changing so fast. It's hard for us mortals to keep our heads above water, I think, with all these new developments. We've got a little time for some questions. I suggest we leave questions about pathology and adjuvant treatment till later in the day when we've got other talks on those subjects. But the questions that don't fall into those categories, perhaps we can address to Ramesh. I mean, one question that springs to my mind is that you haven't mentioned anywhere, Ramesh, the use of RFA to treat tumours, and the sort of the experimental work that's being done across Europe in metastatic GIST, the Mitigate project. Do you know anything about that? I mean, I've been involved in that, but the RFA question, I think you haven't touched on.
Deliberately, I have not touched on the non-systemic options, which include radiofrequency ablation, which we have used in some patients, highly selected group of patients, mostly in the liver, and 1 or 2 patients in the lung. Second thing I've not touched upon is the chemoembolization in patients. We've used 1 or 2 patients, so in Cambridge and also elsewhere. And third is the role of metastatectomy in patients who've been responding to the tyrosine kinase, meaning taking the metastasis out, somebody having liver resection or peritoneal resection. The trial which EORTC started for the metastatectomy has been aborted. There were no takers, basically, because we actually won 2 groups, believers and non-believers, basically. Most of us believe that metastatectomy is probably good, but we don't have evidence to support it. I carefully select my patients for metastatectomy, and by saying that, I'm actually introducing a bias into the decision-making algorithm by carefully selecting, meaning good performance status patients and potentially resectable disease. I insist I can take it out. So that's the issue about the non-systemic options, local treatment options for patients with metastatic GIST. My personal opinion is that we should discuss these things with the patients. If the patient's tumor is potentially ablatable, meaning that they can undergo radiofrequency ablation safely, and you got the expertise to do it. Doesn't matter the expertise sits 150 miles away, they should have a consultation. The difficulty with that kind of thing is that sometimes we may not have the local expertise to make the decision within our MDT, within a cancer center which doesn't treat that many patients with RFA. That's where some of the difficulties arise, in the sense that how to choose these patients. And also, in the lifetime of the tumor, when do you use these non-systemic treatment options? The mitigate study, as Judith was mentioning, this is something which is happening in Europe, and how we integrate with that is something which at the moment is not very clear. It's looking at various non-systemic interventions in patients with GISTs. I have some ideas about how I would do for my patients with regards to where would I choose my metastatectomy. In the first line mostly. I very rarely do metastatectomy in the second line unless the patient has a local problem, bleeding, pain, etc. So patients who are on imatinib, if we feel that it is safe to do, especially with liver metastases, we have offered liver resections as part of the treatment plan. They go back onto the imatinib after having had the tumor removed or some metastasis removed. Interestingly, the patients who have the longest survivors are the ones who have had metastatectomy. It doesn't mean that that's the right thing to do, but the patients who have had the metastatectomy actively taking the residual tumors out, it makes sense from the patient point of view. If your secondary mutations are going to develop in those metastases, why can't you take them out? And because there's never been a randomized trial to support that, we can't give a scientific evidence-based answer that it's the right thing to do. But most of us believe, if you ask off the record, I'm going to be on record now, but off the record, if you ask, a lot of say, yeah, fair enough, I think what you're doing. I think then the question is balance between the risks of that procedure against the benefits. If the risks are too high, you got a 10%, 15% mortality of dying from the procedure, maybe you shouldn't be doing it. But if you've got expertise, again, that goes back to centralized services. These are highly specialized procedures, should be done in big centers, maybe 4, maybe 5 in the country, maybe 2 in the country, that kind of thing. So that's where we have to have those discussions with the patients.
Thank you. Any other questions for Ramesh before we move on to pathology?
You said earlier that mutational analysis helps prognosis. It's quite earlier in your... So if my biopsy says that mutational analysis can be done if they so wish, so it obviously hasn't been done, should I suspect my prognosis, which is reasonably good, of a non-recurrence?
So if somebody got a primary GIST removed, there has been data which has accumulated over the last 8 years now that certain types of mutations tend to confer a higher risk of relapsing. For example, within the KIT gene, the different exons in the KIT gene, different types of exons, different numbers of the exons. We talk about 8, 9, 11, 13, 17, that kind of thing. Exon 11 is the most common mutation we see in that particular exon. Deletions tend to carry much worse prognosis compared to insertions and point mutations. So within that exon 11, the type of mutation, whether it's a deletion or a point mutation or insertion, there's a difference between the two. The patients with exon 11 point mutations and insertions tend to have a better prognosis compared to exon 11 deletions. Again, the problem is this never been incorporated into a validated prospective big registry, big database kind of thing. This is the things, papers have been published over the last 8 years or so. Just if you have a group of patients, you cough 10 times, I cough 4 times, maybe I do better because we compared between 10 and 4. But again, we just need to be careful about how we interpret the mutational testing data in the primary GIST. In the metastatic GIST, the French have done a very, very interesting study in the exon 11 patients. And what they've done actually is, exon 11 is about that wide, it's that big. And we start from about codon 550 to say 580. And they worked out that actually the 557, 558 has got a more aggressive behavior prognostically. Though it's very, very sensitive, very exquisitely sensitive to imatinib, but it's got a much higher risk of progressing compared to 574, 576 or 550. And that's been our experience as well. But how you incorporate that kind of information, which is retrospective, single incident series into a general, that's why when I talk to my patients, I do not talk about mutational status for predicting prognosis or risk of relapse. I just use the validated data, which is the site, size, and mitosis.
Right, I think probably at this stage.
About
my treatment is finished on December 2015, and what it occurred to me a lot, I stopped the protection by the Glivig, and I will be on more risk if my cyst come back.
so you had tumor removed, is that right?
Yes, I have removed 1 year ago, yes, and I have 3 years treatment.
3 years treatment.
Yes, and I read about generic Glivig, genetic Glivig. Do you have some information about how will be available for us to buy? Thank you.
If you have a high risk resected cyst and your adjuvant imatinib, the standard recommendation for 3 years. So that's standard now. I deliberately didn't mention the study which we're going to put through CTAC very soon. The Scandinavian study, they're going to randomize patients who are on adjuvant imatinib now or who are finishing in the next 6 months or so. They would be randomized between stopping the imatinib as per the standard practice or adding 2 more years of imatinib in the adjuvant setting. That means they get 5 years in total. That study has been approved, has got the ethical committee approval, and we're going to putting it through the CTAC. 5 centers will be taking part in the study. So patients who got high risk cyst resected, they're on adjuvant imatinib now, but not as yet completed the adjuvant imatinib, they will be eligible to take part. And the randomization is between stopping the imatinib as per the standard practice, which is 3 years, or having 2 more years of adjuvant imatinib. So in your case, as it stands in 2014, we recommend 3 years of adjuvant imatinib and watch you carefully. And what we learned from the German Scandinavian group is that the risk of relapse in the first 12 to 18 months is very, very low. It seems that the relapse is being pushed further away into the future. So what I tend to do now is that I do a baseline scan when they finish the adjuvant imatinib, tend not to do any scans in the first 6 months, knowing that the risk of relapse is very, very low, but start scanning them more frequently from year 2 onwards, because that's when the risk starts going up. So it's completely different to what you did in the adjuvant setting before you had adjuvant imatinib. Other thing it goes back to is mutational testing. You need to have the mutational testing done. You need to know what your tumor mutational status is to actually to have an idea about how you want to frequent your scans.
Right, I think, is it a question of...
In addition to that, just very brief, perhaps comment to 1 or 2 others. 3 years ago today, I had a large cyst removed at North Staffs Hospital. They had no idea what it was. They took it out, and in fact the mutation analysis had to be done in Holland, and it came back about 7 weeks later, and they started me on Glivec on December the 7th. So I'm coming up to the end of the 3 years under Mike Leahy now, and that's it. So I'm in a bit of a quandary. On one hand, I'll be quite pleased to be rid of the Glivec because of eye problems and nausea. But on the other hand, you can understand people are talking about a 5-year extension. Am I going to miss the boat, or can you have a word with Mike for me?
Unfortunately, I think this is the issue with how the process for getting a trial set up. It can take months, unfortunately, and we're putting it through CTAC now, and I can't see this trial up and running before. I got a feeling that before Easter. The other thing is that, as we stand, we don't know whether 5 is better than 3 years. We don't know that. and also the tolerability issues in the adjuvant setting. Or we have seen in our own sort of experience, it's reflected elsewhere in the world as well, that adjuvant imatinib seems much more difficult to handle compared to imatinib in the metastatic setting. That's been our experience. Patients struggle more in the adjuvant setting, either because of the operation, maybe it's because they don't have a cancer, but they're taking a drug which has got side effects. Maybe you're prepared to put up with more side effects when you've got metastatic disease, various issues, various theories about this. But we have seen in the last 2 years certainly more toxicities and more drug holidays, taking some time off for a couple of days, for a week or so before you go back on the drug, that kind of thing in the adjuvant setting than in the metastatic setting.
I mean, to me, that seems common sense. If I were a patient taking the drug because I've got tumours, I would take it. If it's only, well, I might have a tumour and it might help, it might delay its coming back, I think the temptation to have a drug holiday would be much greater. But one issue, I don't want to speak too long because I'm holding up Philip Tanier, our next speaker, but it might be different once Gleevec comes off patent. And I think you mentioned the fact that it was the generic drug might be available, which will probably be a lot cheaper. So it might affect the way it's prescribed. Is that wishful thinking?
Unlike some of the chemotherapy drugs, as far as adjuvant imatinib is concerned, we are very clear about what the guidelines say and what the evidence says. So switching from Gleevec to a generic imatinib may not have a huge impact on our prescribing the practices, because in the rare cancers, you tend not to do things ad hoc just because you got on the other side of the bed. You don't want to prescribe something, because they're very clear. Adjuvant imatinib, high-risk patients. Perhaps in the intermediate risk, you want to have a dialogue with the patient, see how they want to play it. But the high-risk, imatinib sensitive mutation, adjuvant imatinib, 3 years. In a clinical trial, 3 years versus 5 years, that's a clinical trial question. But in real life, 3 years, as the evidence goes. So generic imatinib may not make a huge difference to how we prescribe, especially with NICE having approved adjuvant imatinib.
I think I'm going to have to call a halt here, because is it about... Ramesh wants to go, he's got a plane to catch. Can it...
It's important from what we've just discussed. I know you're in a hurry to move on, but... I was involved with the NICE committee meetings for the acceptance of imatinib for adjuvant treatment. Went to Manchester at NICE headquarters and in that committee meeting as an expert witness. And one of the things that they made very clear in that meeting was, because we don't know whether there's any further survival benefits to taking it for more than 3 years, 3 years was all they would look at. But an important point that was made there was those that have been on adjuvant imatinib for 3 years with no recurrence, who come off it, can go back on it if there's recurrence. So that question of, am I going to survive longer if I stay on it, it's kind of irrelevant, because at the moment, without the further trials, because you have the opportunity to go back on it and funded by the NHS.
Yeah.
There's a big difference in how you define that going back onto imatinib. In the adjuvant setting, you do not have cancer. You're taking it to prevent the cancer from coming back. Once it comes back, it's metastatic disease. You're taking it indefinitely as long as you get the benefit. So there's a big difference between the two. That is, first intention is curative intent. This side is metastatic, it's palliative intent. There's a big difference between the two from our point of view. Metastatic disease, you keep taking it indefinitely. There's no endpoint. As long as you keep responding, you keep taking it. Whereas here, there's a definitive endpoint. 3 years, you stop.
Right. Well, that's been fascinating. Thank you very much, Ramesh.